You are listening to the Movement Therapy Podcast.
Hello everyone and welcome back to another episode of the Movement Therapy Podcast. I'm joined here by Ethan and we're getting into the shoulder now.
Yes, we're moving on.
We're moving on from the knee. It was fun while it lasted, but jumping right into the shoulder. So running through the anatomy and physiology today, just getting the basics down to start moving into some more common shoulder injuries. That sort of thing.
Yeah, so we'll get stuck into how it moves, how it works, just the basics of it. It'll flow similar to the knee episodes that we did originally, where we discussed what the knee was and its components, and then we looked at specific things. So we looked at ACL. For the next couple of episodes, we're going to be looking at common rotator cuff injuries, which is probably one of the most common issues we see in the clinic, and then also instability or dislocations. I think that's a big one.
And I guess luckily for people that watch our video format podcast, we've got shoulder.
We're joined here
with us
by a prop, ladies and gentlemen. We've got new chairs, we've got a plant, and now we have props. It's only getting better and better now, isn't it?
Production value's
the budget's gone up.
So our third plant over here is actually a shoulder.
It's a shoulder joint. So this is great. Let's get into it.
Let's do it.
Now, the shoulder joint is a really tricky one because it's, when we're talking about the shoulder, it encompasses 3 bones.
Yeah.
And I'll grab our little friend later, but we talk about the shoulder as a girdle as well as the hips and pelvis. So really you've got a shoulder girdle that covers the whole sort of shoulder, sort of on top of the neck, or the neck, and then the shoulder girdle, then the ribs.
Right. So both shoulders are included.
Exactly. Yeah. And then the pelvic girdle as well, which is the
sides of the
gateway to the lower limbs, essentially. So we're focusing on the shoulder girdle for the next few episodes. So for the viewers, this is our shoulder. This is actually a right shoulder. Not that that's super important, but anyway, we're going to keep going. So the 3 bones of the shoulder joint, you can see we've got the humerus or the arm bone. You've got the collarbone that runs through the front, and then the shoulder blade or the scapula that runs along the back. So if we start with the actual humerus here, that's called the glenohumeral joint.
Yeah.
So it's the humerus. The ball is inside the socket of the glenoid cavity of the scapula.
Right.
So essentially, this is one of the most mobile joints in the body. I think it's the most mobile joints in the body. And if the way it was described to us, I'll never forget it at uni. I don't know why it's always stuck with me, but if you get a little, those little saucer plates, like a little coffee tea cup plate, and then put a golf ball in it.
Right.
So that's the glenohumeral joint. It's super unstable and it is very, very mobile. So we'll talk about the movements in a second. That's going to be the main, I think when people talk about the shoulder, that's what they talk about, the glenohumeral joint. So from the back, it's the humerus attaching into the scapula there. So let's go on top of that, and you can see the collarbone as that attaches into the scapula via the acromion. So that's the attachment of the collarbone to the clavicle. Clavicle to the scapula.
So the scapula, for those who aren't watching the video, the scapula kind of has a bit of bone that picks up at the back, and that's where the clavicle or the collarbone
it's almost the roof of the shoulder. The scapula forms, which is called the acromion, and that is it's the top of the shoulder, the roof, and the clavicle, the collarbone attaches to that. And that gives it support and attachment into the sternum on the front of your chest. So again, it's a way for the arm to be attached both to the front and to the back of your trunk, just to give it some more support. So this is where the girdle comes in to hold
I guess it's kind of how your arm is attached to the rest of your
body.
Yeah.
And if it didn't have front and back attachments, you wouldn't have a very successful upper limb, I don't think. So that joint there is a very important one. It's called the acromioclavicular joint, or the AC joint. I think a lot of people out there have injured their AC joints, and that is where it is, and we can talk about that a little bit later. Then the not so common joint that we know is to do with the shoulder blade. So the shoulder blade has to sit on something, but it actually sits on the ribs. So the ribs sit behind the shoulder blade.
Yeah.
And this is called the scapulothoracic joint.
Right.
So super, super important joint, but very sort of under rehabbed, I guess, in the world of conventional shoulder physio and that sort of thing. So we'll talk a little bit about the scapulothoracic joint and its movements, and then the relationship between the scapula and the actual humerus as well. So overall, shoulder girdle, 3 bones: collarbone, shoulder blade, and humerus.
Pretty intricate when you go into it.
It's a much more complicated joint than the knee.
Yeah.
So we're going to try and keep this anatomy session brief because we would literally be here for 10 episodes if we just did shoulder anatomy. There are so many intricate things to go on, which is why the model helps, hopefully.
Yeah.
So watch this episode if you can.
So I guess after the bones, you're going to be looking at the ligaments.
Yeah. So in terms of the ligaments, I mean, it's sort of roughly where these pink bits are on the bones, but really the ligaments are there to reinforce the joints.
Yeah.
And if the ligaments, weren't there at the joints, it would only be relied on via the muscles, and the muscles just wouldn't provide enough stability.
Yeah.
So we've got sort of 3 main sections of ligaments for the shoulder girdle. We'll start with the glenohumeral ligaments, and these are the ones that cover the glenohumeral joint. So the humerus and the shoulder blade, and they form the shoulder capsule. So picture that orange skin around all the segments of the orange. That's the capsule of the joint. Every synovial joint in the body, which is most of the joints, has a joint capsule. So this is that covering of it that sort of encapsulates every sort of all the fluid and all the vessels and things inside it, and just gives a bit of a protection to the joint. So it's not, I guess it's just a bit of a cushion for the joint. So the glenohumeral ligaments connect into the capsule and form this capsule, which prevent the dislocation or reduce the risk of the dislocation of the shoulder. Because if you picture that golf ball again, it's quite easy to move around that plate. Yeah. So if we didn't have these ligaments, you would be dislocating your shoulder every day, unfortunately. And people who have dislocated them know what I'm talking about. The next ones we're going to talk about are the coracohumeral ligaments. So this guy here is an interesting little bone. It's the bone that juts out the front of the shoulder blade. So if you're standing face on, you could feel it through if you just touch the collarbone, and if you go underneath that and dig quite hard
that hurts,
through
actually.
your pecs.
Went to the gym yesterday.
So it will be uncomfortable, but you can feel the coracoid process, which is the little bit that juts out of the shoulder blade. The ligament that attaches this to the humerus, and then this to the shoulder, the collarbone. So you can see those ligaments there. So the coracohumeral and the coracoclavicular ligaments. We love this as anatomy because ligaments were always named for where they were attached.
Yes,
So it was super easy to identify ligaments. You just labelled what bones they were and sort of hoped that you got them in the right order. And 50% you got it right.
Yeah.
That's fantastic. So all of these are to maintain the bone positions within the girdle. So they're rigid, they're strong, they don't stretch. They are passive structures that form the sort of, the structure of it.
Yeah, they hold everything in place.
Exactly.
Pretty much.
There's one that we didn't mention in there, and this guy shows it really well, actually. You've got, obviously, your biceps muscle at the front of your arm.
Yep.
The tendon of the biceps runs along, and we'll talk a little bit about this as we talk about movement, but it forms a little pulley system with the shoulder.
Okay.
But it runs through a groove of the humerus on the front of your arm.
Interesting.
It's in itself is covered by a transverse ligament, and that keeps it in the groove. But you can sort of dislocate this ligament as it falls out of the groove sometimes. It's not good. You shouldn't do it. But it forms a really important part of shoulder movement. But the biceps actually attaches to the shoulder blade.
Right. And then what else have we got?
Yeah, so the other structure that's really commonly injured in the shoulder is bursa, which we talked about briefly in the knee. Essentially, there's these sort of fluid-filled pillows, if you will, that are there under a really high friction environment. So normally they are sort of underneath a tendon or a ligament to stop it from rubbing on the capsule and creating friction and heat. and just to prevent a little bit of pain and I guess as well preventing the degeneration of the capsule and the ligament. Now, unfortunately, these can get compressed themselves and can get irritated and inflamed. Yeah. And as soon as a bursa gets inflamed, you're probably going to feel it. So the main bursa that we'll have is our subacromial bursa, and that sits just underneath the roof of that shoulder blade, that acromion. And this is the one that gets a lot of flack for your rotator cuff injuries, because your supraspinatus tendon, one of your rotator cuff muscles, actually runs through that space. And if the bursa inflames, it's going to squash that tendon.
Yes. Yeah.
So everything is in quite a small space. Now, it depends on the type of person, but your acromion will either lie fully flat, it'll be tilted up, or it'll be tilted down. So there's different variations, and depending on your anatomical anomalies, that will dictate how big your bursa is and where it sits and how easily the tendon runs through it. But you also have different bursas in there. You've got your subcoracoid and subscapular bursas that sit underneath the collarbone and the scapula as well. So they're good, but you don't want them inflamed.
Yeah.
The labrum. So I wanted to bring that up as our last passive structure.
Yes.
So this is the covering of that saucer. If we talk about the plate again and the golf ball.
Yes.
The labrum is the ligament that runs in a circle, that circumference around the plate. And essentially that's designed to hug the golf ball.
Okay.
And to keep the golf ball in place.
Right.
It's not massive, unlike the hip, which is a really formed ball and socket.
Yeah.
The shoulder is
quite shallow,
and it really relies heavily on that labrum to keep the ball in place. But it needs to be that shallow to allow full movement of the arm. So that's an important one, and can get torn if you dislocate it or repeatedly doing overuse injuries and that sort of thing, which we will talk about in the dislocation episode, I'm sure.
I'm sure we will. And then so we've gone through the passive structures.
Yep.
So moving into the more active ones, what have we got?
Yes. So if we go through the muscles, again, if we did this properly, we could be here all day because everything's connected to everything.
Yeah.
So we're not going to brush over. We're not going to go into the rotator cuff right now because we'll go into that next episode. But know that there are just 4 of them, and they are attached to the shoulder blade and into the humerus as well, and they form sort of one massive tendon. But we'll talk about that next time. So at the front of the shoulder, you've got your pecs, if we start with those. So pectoralis major and minor.
Yep.
So your pec minor is actually attached to that coracoid process at the front of your front of your scapula.
Yep.
Not actually your humerus, but your pec major is attached to the humerus. So these, again, they do sort of a million different things. The pec major is split into 3 different heads. So one actually attaches on to the sternum, one attaches onto the ribs, and then one attaches a little bit lower onto the costal cartilage. So you've got your 3 sort of heads of your pec major. And then obviously the pec minor just attaches the ribs onto the coracoid process.
Right.
So mainly the main one on the front is that pec complex. But you've also got the deltoid. So the deltoid covers the whole shoulder, but you've got fibers on the front, fibers on the top, fibers on the back.
Yeah.
And they work together, but they also work sort of separately on their own. But that's, again, the main when someone thinks about the shoulder, they're going to think about their deltoid.
The delts, yeah.
And that's the one you can see on the side, that sort of
You can
forms.
see, can you? Yeah.
Probably not on mine, but maybe yours. I noticed you gave me some eyebrows on that one. That was a bit rude. On some people, you can see the deltoid.
Yeah.
And it forms this V, and it sort of sits into the middle of that humerus.
Yeah, it's kind of like a teardrop shape on the top there. Yeah,
exactly, when it attaches. So then we talk about the long head of the biceps at the front. So I mentioned this briefly, this little tendon running through there. Super important muscle. And it's sort of held on by a bunch of tissues and things, and that transverse ligament on the front of that humerus. But it's got a little groove in that bone just to keep it in line. But it is so dependent on this structure, because if it falls out of that groove, it's not going to turn the right degree. It's got about a 30-degree turn, I think, to actually attach onto the shoulder blade. And this is super important for the pulley mechanism of the shoulder, that if it does fall out of that groove, you're not going to, or displaced by the tissue at all, or get compressed, it's not going to produce enough force or the correct force to help in shoulder flexion, even though the bicep works for the elbow predominantly.
Right. Yeah.
So it still helps in a bit of shoulder flexion. But it also is a shoulder stabilizer. So it helps keep the shoulder in place along with the rotator cuff. So they're all the sort of muscles on the front of the shoulder. If we turn onto the back, I hope you're still with us.
There's a lot going on.
Zoe, are you asleep yet?
My eyes glazing over a little bit. But...
All right. I'll try and keep this one brief. The back, we've got the trapezius, I think, is, again, the one that, or the traps, the one that's talked about the most.
Yeah.
And given the most flack, everyone thinks that they've got a knot in their trap muscle at the top of their shoulder. That's very rarely the case. And there's actually no such thing as a muscle knot.
No.
What they're probably feeling is a trigger point. Anyway, we'll talk about that later.
Another episode.
So you've got your upper trap that sit at the top here and attach up onto the top of the shoulder blade. Then you've got your middle trap that the fibers run horizontally across the back.
Yeah.
And you've got your lower trap, which then the fibers run in a sort of diagonal way. So the fiber's shape is different, which means their direction of pull is going to be different.
Yeah, okay.
So even though it's one muscle, like the deltoid, they do different things.
Yes.
Same as the pec, because the fiber line of pull is different.
Yeah.
And so they're going to do different things. Now, deeper to that, you've got your rhomboids, your major and your minors. Again, most people have heard of these ones that attach the middle of that scapula into the spine or into that middle part of the rib head and spine. And again, just as a caveat here, everyone thinks that they need to do big shoulder squeezes to get their rhomboids going. The rhomboids are there to help the stability of that shoulder blade rather than the pinching movement. The shoulder blade should really never be pulled together in these movements. They need to be stabilized. But we will go through that when we talk about the movements. And then you've got arguably one of the most important muscles, not commonly known, but the serratus anterior.
Yeah.
Now that attaches underneath the shoulder blade on the inside, and then wraps around the body and kind of attaches onto the outside of your ribs. On that side. If you looked at yourself in a mirror and put your arm up and you saw this like a serrated knife kind of pattern, that's your serratus anterior.
Right.
Everyone kind of thinks it's just your ribs.
Just your ribs.
Yeah, but it's the muscle sitting on top of the ribs, and it's your serratus anterior.
Interesting.
Now that's the job of that muscle is to pull the shoulder blade onto the ribs. So it actually forms this scapulothoracic joint, essentially.
Right, okay.
So it's a super important muscle. Now then you've got, as we keep going down, the teres major. So this is a bit confusing because the teres minor is one of the rotator cuffs.
Yeah.
So I think I'm losing you a little bit, but I'll hang in there. So teres major is a super big one, muscle that sort of runs diagonally along the bone and attaches to the humerus. Then what have I missed? The latissimus dorsi. So that is attaching to the shoulder joint and moving back into the back, into the lower back. Huge, big muscle. Again, everyone knows how to do a lat pull down. So that muscle typically works for that movement of moving the shoulder down. I didn't mention as well the levator scapulae. So that muscle is attaching underneath the upper traps at the top, and it's designed to pull the scapula up towards the head. And I think that's it.
There's a lot of muscles in there. Everyone has a job, but there's a lot of jobs.
So I hope you can appreciate, if you've ever injured your shoulder, this is why it takes so long to rehab a shoulder.
It's extremely complex in there.
It's super complex. And normally with shoulders, we find that there's not that many acute injuries. Normally they happen over time.
Yeah.
So we see a lot of those, and you'll talk about it with your common issues that later on. But we typically see that the muscle and tissue degenerates quite slowly in the shoulder because the body is quite good at cheating and compensating, and we have a lot of muscles around the shoulder to actually do that for us.
Yes.
So it's not until 10, 20, 30 years that we might actually have a problem with that shoulder. And it's such an innocuous thing. Like, I know I was doing a shoulder press that I do every day, or I was moving this pot plant from one side to the other, and then, my shoulder went. It was probably years and years and years and years of compensating because of all these intricate structures that work together. They can often cheat off each other. So the shoulder's a tricky one to retrain. We've got to find which one of those muscles is actually the problem.
Right.
And that's the tricky part.
So with the muscles, you get movement. So what are the common movements you get from the shoulder joint? I don't think our friend here is going to be doing too much.
Yeah,
but
which is probably a good thing because we can actually talk
put him
rather
back.
than, So like I said, the shoulder is the most... the glenohumeral joint specifically is the most mobile joint in the body.
Yeah.
So it has movement in every direction.
Yes.
So we've got flexion extension. So if you just bring your arm straight up forwards, that's flexion.
Yeah.
If you bring it down and then backwards straight, that's extension.
Yeah.
So flexion, extension, the main ones. And then abduction is if you were to make a sort of, what am I doing here, Zoe? Like a half
when
circle.
I was in uni, the way we remembered it, it was like you were getting abducted by aliens.
Oh, that's good. And the arms takes away from your body, to the side. And then adduction
Which
is
just the opposite.
Oh,
I didn't have
you
one
only
for
have to
that.
learn one, don't you?
Yeah.
Yep. No, that's good. So abduction is the arm going out to the side, and adduction is coming back into the body.
Yeah.
But then you've got a little extra ones of those. You've got a horizontal abduction, horizontal adduction. So
It's so annoying.
it's so annoying. I thought this was going to be a difficult one to do, but it's fun. I'm really enjoying it. So horizontal is if your arm is straight out to 90 degrees in front of you. Horizontal adduction is if it moves across your body, and horizontal abduction is if it moves out to the side.
Yeah.
So it's, I guess it's just I don't know how I remembered those ones. It's just a matter of rote learning them.
Yeah,
knowing
pretty
them.
much.
So that's the sort of global straight line movements. Then you've got rotation.
Yes.
So I guess the reason the rotator cuff is named as it is it aids in the rotation of the shoulder. But you've got external and internal rotation. But you've got them from neutral position, which is your shoulder joint just hanging down. So that means internal rotation is the palm coming towards your body, and then external rotation is the palm moving away from your body.
Yeah.
But then you've also got internal external rotation at 90 degrees abduction, which is
when your arm is pretty much straight out at a 90-degree angle.
Yep, to the side.
To the side.
And then palm going up is external rotation, and palm coming down is internal rotation. So there are minimum sort of.
We could be here all day talking about every single way you could move your shoulder.
Yeah, that's the main one from the glenohumeral joint. Actually, no. Circumduction is the other one I wanted to say. So that's the one where you essentially just goes in a circle.
Yeah.
So it's sort of that movement kind of encompassing all the movements together.
Great.
Look, you can also traction it and compress it, but we won't go there. So the main movements, obviously, for that are everything.
Yeah.
And this is why it is such a vulnerable joint, because you can move it in all directions.
You can, do everything.
So the AC joint actually has some movement as well.
Oh, right.
Not a lot, and
Yeah.
it really shouldn't have heaps. If you find that it does, you've got a problem.
Yes.
And it should be level. And if you find you have a step deformity where you've got this like little lip in the AC joint, you've probably had an injury years and years ago, and the ligaments have stretched a little bit.
Yep.
They typically don't come back to their original shape if they've been stretched.
Yeah.
But the AC joint should move still in all directions, but just at a really small rate. So normally just up, down, forwards, backwards, and it should be able to traction and compress.
Right.
So they're kind of, it's much easier than the actual shoulder.
That's an easy one.
That's it. I did want to mention the scapulothoracic joint.
Okay.
The where the scapula or the shoulder blade attaches onto the ribs.
Yes.
Because that's a super important joint. Typically for the shoulder to move, the glenohumeral joint to move, the scapula needs to get out of the way.
Yeah.
Right. Otherwise it will impinge, and a lot of the time people get diagnosed with impingement.
Yeah.
Where the humerus actually hits the acromion. Because the shoulder blade hasn't got.
Fun.
It's not fun.
It's not fun.
It hurts.
Yes.
And then you stop moving your shoulder.
Yes.
And the way the shoulder blade typically for the first 0 to like 80, 90 degrees of arm movement, of humeral movement, the shoulder blade shouldn't move at all.
Yeah.
Really.
I think you can also just feel it as well when you move your arm in any of these.
Yeah. So if you're if you're under shoulder height moving your arm, the shoulder blade shouldn't move.
Yeah.
Right.
Theoretically.
Roughly. Yeah. Now, when you move your arm past that 90 degrees and you're starting to go over your head and past that sort of 90, 100 degrees, your shoulder blade has to move to the side.
Yeah.
And we call that outward rotation.
Yeah.
Some people might have a different word for it, but typically it spins on its little axis along the scapulothoracic joint, hoping that the serratus anterior is pulling it into the ribs, so it's not coming off and winging. But it needs to turn outwards so that the shape of the saucer of that glenohumeral joint actually opens up and allows the shoulder to go fully overhead.
Interesting.
Yeah. And when it starts moving, it's got about a 2-to-1 ratio with the humerus.
Okay.
So typically the humerus moves 2 degrees for every 1 degree of the shoulder blade.
It's interesting how everything plays a part in everything pretty much.
Yeah, especially with the shoulder, it's so dependent. Everything is dependent on everything.
Interdependency between different regions in the shoulder.
And because, say the collarbone, because that is attached, 50% of it is attached to the scapula. If there is a problem with the scapula, there's going to be a problem with the collarbone.
Yeah.
And that collarbone comes into the sternum. And so therefore the sternum might be, in trouble a little bit, and then all your ribs attach into the sternum. So then you might have rib problems purely based off your shoulder blade. So there's different ramifications that this might have.
Yeah.
But commonly vice versa, if you have a problem with the ribs, because the shoulder blade is attached to the ribs, you might actually have a shoulder problem that is manifesting from a rib issue originally. So the ribs might cause the shoulder blade not to move as much, and therefore your shoulder joint is not able to move, and you might get these impingement symptoms.
Right.
So this is where the assessment in the shoulder, when you come into the clinic, and we'll talk about this in the next few episodes, is full body.
Yes.
We have to look at your neck. We have to look at your spine. To be honest, your neck and your thoracic spine are more important than the shoulder if you have a shoulder problem.
Right.
So we need to clear both of those in order to make sure we're treating the right thing.
Because the body is all connected.
It comes back to that every time, doesn't it? It's super annoying. And people are like, stop saying it. But if you can understand that, and you come in here and sort of, one of the clinicians is treating your neck, that's why.
That's why.
Because your shoulder is part of your neck.
Now, there's been a lot of content today. It's been a lot of learning.
It's a big day.
It's been a big learning day.
I apologise.
I've got some facts about shoulder injuries and like the prevalence in Australia.
Yeah, that'll be good.
So across all age groups, shoulder and upper limb injuries were around 360 per 100,000 injury presentations.
So that's across all of Australia?
All of
any
Australia,
age group?
all ages. They were also one of the top
heaps.
3 most injured body parts.
Wow.
Yeah.
Do you know what the other two
I think it was head and neck.
Really?
Was one of them. And then the other one was, I'm not going to try.
Well, if you just listen to the 10 minutes ago of the podcast, you'll know why injuring the neck actually injures the shoulder as well. So they could be interrelated.
They could be.
Interesting.
In Australia in 2022 to 2023, there were 94,800 cases of hospitalisation due to shoulder.
Hospitalisations from shoulders.
Shoulder and upper limb injuries.
So what would they be? Like fractures and stuff?
Yeah, so 66% of them were fractures.
Wow.
57% of all cases came from falls.
Yep.
I think, you could have any reason under the sun you've got a shoulder injury. Had a friend dislocate a shoulder in their sleep.
Yeah,
So
rolling over. That's a really common one, ironically. But
Yeah.
I had some swimmers, rock climbers, AFL players.
It can be anything. And I guess like the knee we discussed last time, it doesn't have a certain demographic.
No.
It's anyone and everyone.
Yeah,
exactly. Because you can do so much because there is so much going on in there.
Yeah.
But I guess the most common presentations or most common injuries, as you said, is a rotator cuff or impingement. And then also your dislocation and instability, which luckily we'll be speaking about in a lot more detail because it is something that is so common. It's sports, but also just
it could be anything. But and again, genetics play a little bit of a role in this as to the shape of the shoulder joint, and the next caveat to that is the function and the compensations that you already have. Because if you live with these compensations and you grow them and you strengthen them, and you go to the gym like we tell you should, then you're strengthening the compensations if you don't know, and then suddenly you have a fall or someone knocks you the wrong way or what have you, then you're just, you're knocking over the domino stack and everything falls down.
This is an interesting one as someone with shoulder instability who
you form a lot of these, Zoe.
I know. Ethan, it's because the whole body's connected.
That's very good.
That's
very
why.
True.
But I have fallen into a lot of these categories we've talked about coincidentally. But I guess also the other ones that came up were bursitis and AC joint injuries, the
Yeah.
acromioclavicular, which we spoke about before.
And this is where you get more acute injuries.
Yeah.
In the bursitis world, in the AC joint, where it's more sort of impact, as well as the general humeral fractures and that sort of stuff. But yeah, they're your more acute sort of injuries.
Yeah. So from there, I guess in later episodes, we'll be speaking about your rotator cuff and impingement kind of issues, and also instability and dislocation.
Yep.
Just as some that are quite common and also easier to discuss for us.
Yeah, right now.
We're not going to go through too much content heavy again.
I think we've done the main content of the shoulder.
But when you are treating people,
Yep.
what are the common things that you see come into the clinic shoulder-wise?
Great question. And that's such a variable answer. The main one, I think, sort of is guarding.
Yep.
And that sort of fear of where you pull your arm into the body and you almost hold it like a sling.
Right.
And that could be whether it's acute or a chronic injury, where you've got pain because the weight of the shoulder is actually pulling down on whatever structure is damaged. So if you have a subacromial bursitis, you're not going to want to let the arm hang down because the arm is quite heavy.
Yeah.
So you're going to want to pull it into your body and keep it close. And that is that classic sling position, which is really bad unless you are actually wearing a sling.
Right.
Because when you're wearing a sling, you can relax.
It takes the weight
exactly
off you. Yeah,
without your muscles holding it.
Yeah, it's something that we just do without knowing sometimes, is bringing the extremities, so your arms or legs or whatever, closer to the midline, the middle of the body.
Yep. To help just to help take the weight off them.
Yeah.
That's sort of number one.
We subconsciously think it's helping, but it's actually a hindrance.
Yeah,
sometimes.
I mean, it might take the pain away, but it's not helping.
But it's,
So, we try and get rid of that pretty quick. But the other thing with shoulders is that they normally, all shoulder issues, well, again, asterisks, but it's super often for shoulders to have a reduced range of motion.
Yes. In
some area, whether that's rotation, flexion, extension, abduction, adduction.
Yeah, you talk about like a frozen shoulder.
Frozen shoulder, you're sort of going to get to 90 degrees, that sort of thing. I've seen, all manners of different shoulder issues, but a common myth is that you lose shoulder range as you get older. I think that's a really interesting one that people say, I can't lift my arm up, but that's normal, because I'm old. And it's like, okay. It is common for your shoulder joint to have degeneration because it is such a mobile joint and we use it all. It's not normal to have any reduction in range.
Right.
Bar being scar tissue from a previous surgery or some anatomical anomalies that create that, you should still be able to express up to, 170, 180 degrees of shoulder flexion, for example, and be able to hang the washing out, put stuff in the top cupboard, reach above your head, do a shoulder press, that sort of stuff. So it shouldn't be a reason that your shoulder isn't working, should not be age as much.
Interesting.
Yeah. I think, especially with rotator cuffs, and we'll talk about this, but normally it is the older population that the rotator cuff starts to degenerate quicker. And, we normally see about, I think it's over 45. I can't remember the research we did for that. But the older population starts to reduce their rotator cuff function. And as soon as you reduce a rotator cuff function, your shoulder becomes unstable.
Right.
So the rotator cuff designed to actually hold the shoulder joint together, the glenohumeral joint in place, essentially. We talk about centration, that word of just bringing the shoulder joint into the center of itself. So the rotator cuff is designed to be able to do that. Now, if the rotator cuff is not functioning as well,
it's not going to do that.
It's not going to do that. So other things will try, but the muscles are too big and broad to help. And so your shoulder becomes unstable. Now, if that happens for 20 years, it's going to be the time when you're about 45 plus is when you're going to have these issues.
Yeah. Well, I think we can stop there. We've done a pretty in-depth overview of the shoulder.
Yep.
And so it's anatomy, it's active and passive structures.
Yep.
And we've also had a look into the common injuries, I guess,
Yeah.
the common problems people have
Yep,
with
absolutely.
the shoulder. And then over the next couple of weeks, we'll be going into our instability or dislocation and also the rotator cuff and impingement issues.
Definitely.
But thank you for
No
sharing
worries.
all of that with us, Eth.
I hope no one sort of fell asleep during those ones. The anatomy ones are always tricky.
It's
We need to find a
hard.
way to make those interesting.
A bit quicker, yeah.
Sorry, everyone.
But as always, if you have any questions or comments or anything, get in touch. Online, we've got our website, Facebook, Instagram. As always, like and give us a follow on Spotify.
And share it around as well.
Share it around with your
Yep.
friends with shoulder issues. I've got a few people
Yeah,
I'll send
absolutely.
this one to. But yeah, stay tuned and we'll be back soon.
Awesome. Bye.